Hello, my name is Megan Kim. I'm the Assistant Vice President of Population Health at Temple University Health System in North Philadelphia. We serve a very large, diverse inner city community with a lean staff of ambulatory diabetes health management program, consisting of 2 full-time dietitians and 2 full-time registered nurses. Our teams, as of current, are embedded in several primary care office locations throughout the city. And we also partner with our specialty clinics, including endocrinology and our Temple Lung Center. Continuous quality improvement is at the heart of our program. It's actually and I'm getting my team to be their favorite standard. We're always trying to innovate and improve our program outcomes, and that has to start at the crux with data. So I'm going to share some examples of how we do this at Temple. But first, we're going to go over the standard and some of the changes. So standard 6, measuring and demonstrating outcomes of DSMES, reads as follows. DSMES service will have ongoing, continuing quality improvement strategies in place that measure the impact of the services. Systematic evaluation of process and outcome will be conducted to identify areas for improvement and guide services redesign and optimization. So, what this all means, there were some significant changes that occurred that from the 2017 standards to now, some of which include the consolidation of the previously known standards 9 and 10 for data collection and continuous quality improvement. There's improved clarity of reporting metrics and outcomes for CQI that's helpful. And, it helps, I think, to provide some clear examples of the components for a CQI project. So why is standard 6 so important? CQI really is a critical component to any service. Programs should never be satisfied with status quo, always looking for areas to improve, move the bar, go to the next level. Aggregating individual and participant outcomes is essential to demonstrate the benefit of your services to organizational leadership, and to the community that we serve. So using the interpretive guidance from the CQ guide, I'm going to discuss standard 6, part A, tracking outcomes, first with some relevant examples, and then review part B, the CQI, and provide our program's initiative to improve key measures. That way, I'll give you an example of how certain programs are actually putting this standard into work. So part A of this standard, to demonstrate the benefit of DSMES service members and track team aggregate relevant participant outcomes. So we have to have at least one category, including healthy eating, being active, and at least one other participant clinical or quality of life outcome. And then these are aggregated. So here's an example of how our program aggregated behavioral goals. This data is actually extracted from our Epic EMR. So we decided internally to build flow sheets to capture our patient education documentation. This allows us to pull some discrete data for ongoing reports and to really capture what's needed for compliance so that we can stay in an ADA program. So like I said, our program is kind of nestled in the heart of North Philadelphia. And in this area, unfortunately, we have safety concerns regarding outdoor physical activity. And that's been identified actually as a social gap for many of our program participants. So with that in mind, our team actually chose to aggregate and then compare the top chosen goal, which was self-monitoring, versus the least chosen goal, physical activity, and then assess the disparity and look for ways to close this gap. So we had several conversations actually with local agencies as a result, such as like the YMCA and local college. Temple University is actually right down the road from us at the hospital here, to partner and improve the physical activity goal for our local residents living with diabetes. So more to come in this next fiscal year. But as you can see, there's a huge gap in between those people in our program who actually chose physical activity versus self-monitoring of blood glucose. So we thought this was a good one to actually share, and we actually showed this as our advisory board as well to get some updates and get their input on how we can actually improve that goal for our participants. So, and the other participant outcome, our program actually chose eye exams. This has been a difficult measure to fill in our organization's practice. I mean, not just here at Temple, but probably this is a universal, very hard participant outcome to fill. Because of this, we now have actually 7 of our primary care office locations with digital retinal eye cameras. And we also have a mobile health van embedded in our population health program. And that mobile health van actually has an eye camera on board. So we're able to take that van out to certain areas of our city that have a very large gap and get that filled with some community events. So our diabetes team decided to track and then aggregate the percent of eye exams on the DSMES participants. So fiscal year Q1 showed that about 23% had a completed eye exam. Fiscal year Q2 showed a decrease with about 20% completion. So with this data that we had at our fingertips, we're like, what do we need to do here? So we did decide to partner with the mobile health van. So this is community health workers that are on that van, some medical assistants, and our diabetes education team decided to partner and market diabetes days at some of our regional office sites. So when we did this in the beginning, you can see the trend up where the red arrow indicates. So in the beginning of fiscal year Q3, fiscal year 23, Q3, which is January, we hosted several New Year, New You health campaigns and encouraged offices to proactively outreach to those with that care gap. While the diabetes team was in the community educating about the importance of the annual test, the offices were closing gaps via proactive outreach telephonically. So we did see an uptick from these efforts. So fiscal year 23, Q3 showed a 29% increase from the 20. And then in the last quarter of that year, we saw a 35% increase from the lowest quarter, which was 20%. So without measuring this participant outcome aggregately, we could have actually missed this opportunity and kept that status quo. Although this was not a formal CQI, this actually became our informal CQI as we began to continue to track these measures. So when you're thinking of another participant outcome to measure, this could eventually turn into a CQI if you want to see improvement in that outcome. Okay, so I'm going to move on to standard 6, letter B, which is your formal CQI. So I just showed you an informal one. We're going to move into the formal CQI. So formal CQI strategies provide a framework to strive for excellence, quantify successes, and identify future opportunities. A through F here indicates from the QC guide some other project outcomes that you should be looking for. We can't talk quality improvement without having the QI cycle here. Again, this is in your QC guide. But it's really important to start with the question, what are you trying to improve? This should not be something that you just check the box to get it done. CQI projects can be fun. You can get the whole team involved, your advisory board involved, other members outside of your program to get involved. But in order to have an improvement component in your program, remember you have to have baseline data so you're able to demonstrate the improvement of your efforts. This picture is just a nice guide to get you through the CQI cycle. Here is actually an example from the CQ guide that can help you organize your quality improvement processes. This is if you're new to CQI. I know those that are, CQI can be intimidating for those that are just starting. But I think that once you get into it and you have a couple of wins, it becomes the most exciting component of the program. It is important, though, to note that DSMES services who are completing an original recognition application are required to have the elements highlighted on this slide at the time of the original application in all items within 6 months of the application. So again, this is a nice template to get you started in your CQI efforts. This slide has a completed template. There's many examples within the QC guide that kind of help you along. So the first one is kind of putting out your plan. What are you looking for? What do you want to improve? This is your cycle of collecting and analyzing the data. So again, it's just a nice way to outline your CQI project. So when diving into a CQI or quality improvement initiative, the team should be cognizant as to what type of measure you want to improve. I go over this a lot with my teams. So this could be a process measure or an outcome measure, and they are different. So process measures indicate how or what an educator or service does to impact the outcome. So it's process. What are you doing? So when there's too much variation in a process, it can negatively affect that outcome. Versus an outcome measure. The outcome measure represents the change in the participant's either clinical, behavioral, or financial health status. So an example of an outcome measure can be A1C, the measure itself, self-monitoring blood glucose daily, decreased ER utilization. And if we kind of give an example of a process measure, let's take A1C, for example. So the process is getting the A1C done. Did your participant get the A1C done? Outcome measure is actually the A1C value. Hopefully it's under 8%. But it's important that when you're coming up with a CQI that you kind of differentiate what are you trying to do, process versus outcome. And remember the old adage, you can't manage what you can't measure. So, this makes good sense in terms of what makes a good process improvement or initiative. You want to make sure, of course, if you're working in a healthcare organization where cuts are almost inevitable across the board these days, that it's inexpensive or budget neutral. That it can be measured. So like I had mentioned before, we use Epic as our EMR. We have everything that we need within Epic. And if we don't have it, we're going to build it so that if we want to improve or have that measure as a baseline, that we have the ability to pull that when needed. You want to also make sure that if you're doing a CQI initiative, that it does have positive effect on both patients and staff. You don't want to do and make a change or do something that's going to result in more work or over redundance for staff, but then positively impacts patients. It really should be both. Important too that it aligns with your departmental and or your organizational goals. That's really great for having a leadership buy-in when it doesn't align with the larger goals of the system. That the CQI can be completed in a reasonable time frame. You know, if this is a CQI that you keep repeating year after year after year, you need to ask yourself, is this something that we should be working on? Or do we need to sit back and say, hey, you know, let's try and get something that can be done within 6 months or done within this calendar year. So important that your CQI is meaningful and that it can be actually achievable. And of course, that you have the available tools and resources. And tools in my eye are good data and a good data analyst if you need help interpreting what that data means. I put this in here as some examples of CQI methods. There's a few. This one is focused PDCA. There's many different frameworks that you can use, but I thought it might be helpful just to add a couple into this presentation. The one that we have actually adopted, the framework at Temple, is PDCA, which is Plan, Do, Check, Act. You know, we do use this for all of our continuous quality improvement across the health system. So in that way, everybody's kind of speaking the same language. In the plan phase, this is when you recognize the opportunity for and plan for that change. So the team comes together, you agree on the project, you clarify what the problem is, and then hopefully at that point you do have baseline data to say, yep, we need to improve on this measure. And during this time, you want to think, gosh, if we're going to improve, what do we need to improve by? Is it a certain percentage point? Is it a number of participants? But think, what are your goals in terms of your outcomes? And then pilot, put some possible solutions on the table, and all of this can be done during your planning phase. During the do of PDCA, this is when you're actually doing the work. You're testing the change, seeing if it's actually fruitful for the efforts. During this, you know, a lot of times here at Temple, we do everything as a pilot. So we want to pilot it, make sure that it works, work out the kinks, and then include it as part of our process. But do is when you're actually doing the work and testing the change. During the check cycle, this is when you're analyzing the data. Were your goals met? Do we need to pivot and change? Are we on the direction to meeting our goals? What other improvements can be made to get us to where we need to be? But that check cycle is very important for analyzing and checking where you are at that point. And then finally, act. If you're complete, what are your next steps? Do we need to go back and repeat this cycle? Again, do we need to pivot? But if you've actually met your goal at the act phase, celebrate your wins and then explore other areas within your service that need improvement. It should always be, that's why it's called continuous quality improvement. You always want to strive to moving your program to the next level. So this is how we've adopted, or this is the framework we've adopted here at Temple is PDCA. So what I'd like to do is actually share our fiscal year 23 CQI initiative. I was going to say our PDCA, but same thing. And kind of give you an idea of how we did this. So our CQI project actually started when we were going through and looking at standard 2. So just as a review, standard 2 is the population and service assessment. So our goal during the planning phase of our CQI initiative was to increase the percent of Spanish-speaking adults living with diabetes who receive formal education. We decided to do this by 10%, because when we were looking at our assessment here, we looked at the community that we serve, and the community that we should be serving, and saw there was a huge disparity amongst our Spanish and English speaking population who actually were referred for diabetes education. And we thought, wow, we are really missing a huge target population. And we do have one of our health professionals, the registered nurse, who is actually a certified educator, and she is trilingual. So she speaks English, Spanish, and French. And we were having very, very poor, and compared to our English speaking patients, poor Spanish speaking participation in our program. So noting this disparity of the population that we are serving versus what we could be serving, we said, hey, you know what, let's make this our goal for the next fiscal year and really start to include more diversity within our program. So the issue being addressed is we need to increase our Spanish speaking patients into our DSMES and MNT encounters. Our project and our team actually had some pretty high ambitions. We wanted to create a culturally competent DSMES curriculum to meet the needs of our Spanish speaking patients. So we were lucky enough actually to have 2 dietary interns from Temple University work with us on developing this Spanish culturally competent Spanish speaking curriculum. And it's novel to our program. So there's a lot of work that went into it, but we're very, very proud of it. We hosted some focus groups that included some members of our community and had direct feedback from our Spanish speaking patients with diabetes as to what they would want in terms of making sure this was culturally competent. And taking the point that we're coming out of COVID, where, you know, group education just wasn't happening here. I'm sure it wasn't happening across the country. So we're pivoting from Zoom and Teams and virtual visits to now one-on-ones and trying to get groups reestablished. What we heard from our participants in the focus group is that they missed that group interaction. So we were really excited to get this going. We actually rounded to our community offices, some that were Temple owned, some that were in the community that we knew had a very high percentage of Spanish speaking patients. Doing some lunch and learns, explaining our program a little bit more to those that were unfamiliar or those that did not routinely refer patients to our program. So a lot of efforts were put into the planning phase of this. Our target outcome, when we wanted to do this, we said, okay, let's increase monthly encounters by 10% of baseline from fiscal year 22. Fiscal year 22, on average, we had about 17 Spanish speaking encounters per month. That was our baseline we were working with. Once we initiated and put all our plans into action, we had our baseline data, we went into the do phase. And started to actually see the referrals pick up, which was really exciting. We actually stopped at the quarter. We had quarterly meetings with our diabetes team, community stakeholders, some of those offices that we visited, and shared the data as it was coming to us from Epic, from our encounters through Epic, those that improved, those that actually showed for the program. So our outcome, our improvement initiatives proved an increase from an average of 17 Spanish speaking participants per month to 42 per month. We had a goal of increasing encounters by 10%. We actually increased by 147%. This blew away leadership here. It actually helped with our social determinants of health assessment internally. So closed some of the care gaps that we were seeing then there as well. We got our participants set up with a lot of other community resources and help that they may not have had access to had they not been referred to our program. So really, really proud of these efforts, very proud of the team, and clearly we met the initiative and our goals exceedingly by over 10%. So we're going to continue with these efforts. We don't have this as a CQI project for next year because we met and exceeded our goals. So for the next time, we're going to stop. We're going to go back to the table and say, what else do we want to include on our program? But we will continue with the same process of increasing our Spanish referrals, just not in formal CQI. So hopefully you find this helpful, that you can take things from other standards, i.e. your assessment of the community, and if there's a big gap there and you need to fill it, you can certainly make that a CQI as we did. Very, very proud of what we were